So, I would like to thank to organizers of the Congress, and also I would like to thank to nice introduction of Mr. Ali. And so I will be talking about the early age psychotic and bipolar disorders. And as you will be see here, so I will be talking mostly about, and I have been working in, we have an early diagnosis program in 9 Eylül University for, and also we have also neuro, neurological diagnosis department also exists, and so I will be talking about neurotypics and also psychotic and as a part of the psychotic and bipolar disorders, and I will be talking about the risk, the prevalent risks. I will not be touching about the elder risks, old age risks. And so, which domains we will be? So, first of all, we will be talking about the neurocognition, social cognition, motivation and effort decision, eye tracking, neuroimaging, retinal imaging, and also linguistic. That we are really so much. And we will be talking about the first episode, and also the first degree relatives, and also youth. And also we will be talking about psychotic bipolar disorder, and converters and non-converters. And so we will be talking about whether they are transforms to each other or not. And so we will be talking about the precision types in order to see there is any transition to psychosis or bipolar disorders. Starting with the cognitive side, on the neurocognitive side, and so I have started to work on the cognitive part as well. So all is known that it is schizophrenia. Then schizophrenia is much more apparent as we know, and especially for the bipolar. And we know that there is cognitive degeneration and alienation, and it can be very severe as well. And these are the group analysis coming from the meta-analysis world. And this is also that it shows that there are three different cognitive groups on the bipolar disorder side. I will not be giving details, not only for the chronic phase, and it's also on the acute phase and all the first episode side. So we can also see there are many different studies on these aspects, and so for the we have also checked about these, and as we know, the negative symptoms and social functioning were associated with the neurophysiological impairment in both groups, and if there is an attenuated positive symptoms, we see that social cognition and neurocognition are much more prevalent according to our findings, and there are different studies, of course, and so and of course for the cognition side, especially for the first aid and for the predicting the relapse, can provide also significant results as well. And as we see here, when we receive the patients, and so we perform the polygenic risk scores have been also evaluated, and so instead of this polygenic risk score of schizophrenia, so we have checked even the cognitive side of psychosis, and for the early period psychosis, we have checked about this precision functioning aspect. It is not only valid for the first episode side, and it also applies for the ultra high risk psychosis as well, and for the non-functional side, and because it shows that the neurocognitive precursors were also bad in that group of patients as well, and especially for we see that it is also applies for the first degree relatives as well, and as we can see the relevance here, and the same applies for the most prevalent studies as well, and we will see that especially on the onset, the psychosis for the high clinical high risk for psychosis is CHR, especially for the onset and also for the remaining side, and of course, especially for the early with for the early psychosis, and it shows that the progress is not the case in most of the cases. Of course, we are updating these results according to long-term results, and for the and we see we are checking whether the first degree relatives and also comparative meta-analysis recognition, especially with the ones with having the schizophrenia and the bipolar disorders, and so for the young familial patterns, we see that there is also a relevance for the bipolar side as well. And high clinical risk studies has for the bipolar disorders, and very few for the cognitive impairment. And there are, for example, for the some of them developed illness, and so there are two studies that are showing bipolar high risk and familial high risk for the subclinical syndromes, and so in these samples as well, so there are some studies that showing that there are cognitive impairment as well, both in our studies in the other studies as well. So if there is a familial high risk cases, the cognitive disorders can be also associated with the bipolar disorders as well, and so for the like the psychosis and the political bipolar disorder may not be aggrieved together with the cognitive cognitive impairments, and so in a recent study actually, and so we have compared the social cognition in youth and young adults at ultra high risk for psychosis and the bipolar disorders, and we have seen that the cognitive disorders applies for both of them, and negative results were associated with with the relevance between the bipolars, and so and we have checked whether there is an the basal difference exists or not for developing the bipolar disorders afterwards. And what about the social cognition? And here, as you see in this meta-analysis study, we call it as a and the called cognitive area, and for the social cognitive area, for the social cognition. So when we compare it with the autism, and so on the neurocognition level, it can it depends on the age that you are checking it, and for example, and so if you check before between 25 years or after 24 5 years old, it changes, and of course it also completely changes in the childhood level, and for the adjusted IQ levels as well, it also differs for according to timeline and according to different parts of the site. And this one of, for example, evidence for theory of mind. And then, so in the comprehensive meta-analysis, we have also checked, and also in the first degree relatives, the social cognition impairments also exist in the for the first degree relatives for the FTRs, and for the baseline social cognition predicted occupational status a year later, And then there are few studies investigating social cognition on the FBD and also for the UHRBD. And so a single study reported impairment in 26 patients, while first episode was not the case. And so for the ultra high risk ultra high risk for psychosis and bipolar disorder was observed. And so and also for the social cognition are not only two domains. It is not only social cognition, and so it is not only for cognitive. It's social cognition also. Also it can be social perception as well. So there are social perception, social knowledge, externalized bias, personalized bias, emotion perception, and so there should be five different pillars of the social cognition. As you can see, it's not only for the cognition, and so the social cognition level disorder can be reflected on the language of the also it can be reflected on some other atypical aspects as well. So and so for decision making among individuals with schizophrenia, and there are different tasks, and also there are so effort tasks, effort cost decision making, and so we this is the one of the most classical tasks that are used. There's a reward. It can be small or big, and so if you win the reward, if you can succeed it, and the probability of being awarded can be high or low, or it can be easy or challenging, and the people tend to select of course the challenging works, especially if the rewarding is high. And so the acting when the rewarding high, so is of course it reduces significantly on the schizophrenia patients. And of course there are also there are one of the few data that exists that says that it also exists for the bipolar disorders, for the BDs as well. And another it's a newly in it's for SG and others has worked about this. And for the about ultra high risk, there was only one study. And okay, for the first episodes, and for the first episode, bipolar disorders, we have studied, and it's on the reporting stage at the moment. So for the effort-based decision making, and this is also. And in psychological medicine, it is about to be accepted. And for the ultra high risk for psychosis and bipolar, it says it exists. And also for the FDRs, it can be for the both types of disorders. For the eye tracking disorders, and these meta-analyses have been newly and it shows in the first episode psychosis and also ultra high risk. It also applies, and for the eye tracking abnormalities, and of course there is very little focus on the early stages of the BD at risk populations, and we don't have too much level, and so there is also there are some studies, of course, for the accumulation and clustering of this for the first degree relatives. And again, for there are SNP studies, and there are also intermediate phenotype of, and it is an ultra high risk for the bipolar disorders, for the individuals, for the and it can be unsaccat and memory guided saccat as well, and although ultra high risk group, and there is significantly decreased number of correct saccats, and also schizophrenia also has significantly, and I will be talking about the neuroimaging. And there are, so of course, I have my own meta-analysis, and if you continue with the Enigma, which is very well known, and of course, control subjects, with the control subjects, there are some differentiations, and however, it can be lower than of course, effect size are higher in the more red areas, as we see that. For the bipolar areas, and of course lesser than the psychosis. And for the cortical thickness, so of course, at different ages, and so for the on the ultra high risk groups, in limited areas affected, as you see here for the psychosis. and and of course we have also network for the fMRI activities for the salience network, and it says that it is reduced. And so we have for the high risk for the psychosis, and so for the default mode within connectivity and the default mode fronto-parietal network connectivity, it is decreased. And in some network connectivity for the visual, for example, default mode visual network connectivity increases, and according to this analysis. And so for the and structural disconnectivity in offspring of individuals with bipolar disorders. And we see here, and for we don't have too much activity or too much studies on the bipolar disorders on this area, on the global disconnectivity were not prevalent on this risk group. And again, for the highly impulsive BD of groups shows significant cortical thickening in bilateral parts operculosis. And I think it was in regard to MRIs. So can we just given and that there are machine learning activities have started so for the, and that there are with the 80%. So it shows that AI and the machine learning can predict 80% rate. And what is the situation on the bipolar side? I think here we see for the Enigma showed it as around 23 or 26, sorry, 63, 65 level. And Mr. Ali has, I have commented him on depression. It is not that bad, but however, it is not also very good with these rates. And so for the basal MRs, and so we have, when we checked whether neuroimaging measures to predict psychosis on onset for the individuals at clinical high risk, there are some, of course, promising positive results, and like 73% here. And I will be talking about retinal imaging here. And for the yeah, it's in retinal biomarker in schizophrenia spectrum disorders, and of course it can be also open doors for the changes in the brain structure. And so it also applies for the bipolar. However, it does not seem to be relevant for the depression. And we have also checked about choroidal structural analysis, and also we have checked when we checked the retina in clinical high risk and the first episode psychosis, and the different layers are affected. And so these symptomatic and cognitive symptoms, so they seem to be moderate. And so we have, when we developed a machine learning model, achieved a mean accuracy of 86% with this for psychosis. And however, for the ultra high risk psychosis, it was a 66% of success rate. And so for the linguistic abnormalities, and there are, and I'm involved in the steering committee of an discourse in psychosis, and especially for the communication abnormalities and communication disorders. And so we have working. It's not an automatic job, and so it's a linguistic part of this linguistic study actually. And so we have checked that the reference anomalies are more prevalent. And so together with the DARIA for the ultra high risk psychosis, and also first episode psychosis, and also familial Psychos applies more and more relevant for this aspect, and is for the sentence making and sentence formation. And for the linguistic production and synthetic comprehension, schizophrenia and bipolar state, yes, we have some sets of data, even though they are limited, especially for the syntax level and also for the comprehension level as well. And so actually cognitive and linguistic correlates positively and negative formal thought disorders. And so we see that together with the neurocognitive side and the linguistic correlates to each other, and especially for the Turkish-speaking patients as we constitute our samples. And so we work with the chronic schizophrenia patients, and so we have seen that the similarity in the with the speech patterns are really increases, and so we can also perform the patient and control group differentiation, and especially for the analysis that when we performed on the talks for about 20 minutes or more. And okay. Yes, for the first episode, psychosis, and also for the clinical high risk area, we have limited studies. And so, for example, in one study, it says that it predicts around 80%, and so there's a paper on the review, and especially for the critical high risk psychosis individuals, and it shows that around 68% of relevance it shows according to a paper under review. And again, for the when we another of course another article that's uh, under the review of the referee between the FEBD and the FEP, and the first episode bipolar and also first episode psychosis were associated with the use of shorter sentences and increased sentence level similarity, but with less semantic alignment. So we have also significant with the symptoms that were found. And also it shows that speaking patterns of these three groups. And again, so we checked the similarity, mean or pair similarity, and between the visual shown, and also similarity between the text, and especially is of course the acoustic. When in terms of assessing the acoustic patterns, we see that there can be distinctive acoustic differences between the control group and the bipolars, and so we can compare it with the autism, and also we can also compare it with the elders as well. And however, we can say that when we look, we can check many different markers on one side, and however, heterogeneity on, and if we, for example, bipolar and if we check the bipolar and the psychosis, and of course, if we see that psychosis risk increases for the lower ones, and so that there is different pattern here, as you see here, between the IQ and also page. When we look at the common and the distinctive genes for the IQ level and the patient disorder, and so there are of course genes related to the concordant blocky also differs from. Sorry. So I would like to mention one more time that there are many different biomarkers in different levels, in different phases of the patient, and however, of course, heterogeneous structure of the patient is also one of the most important challenges for us, and it may not be applied for all patients. And however, of course, the discipline, of course, will be bearing new horizons for everybody, I think, especially for the postdoc, postdoc students, Berna, and also Master of Science students, Yaren, and others, and clinical studies, and also collaborators, Çağatay, Merve, Güneş, and also I would like to thank, and also Merve Ekin, I would like to thank, and also I would like to thank to Derya Çokal and also Wolfram Kinsen. I would like to thank to all of them. And so not for this study, and however, so I would like to thank our lab members, the all other friends and colleagues. Thank you very much for to all of them for contributing to our efforts. Thank you very much for listening to me patiently.